Good evening, everyone. Warm welcome to the fourth day of Oral Cancer E-Conclave organized by ICanCaRe Sterling Cancer Hospital and FHNO, Foundation for Head and Neck Oncology. We are on the fourth day. In the last three sessions, we have had prolific discussions about challenges of diagnosing an oral lesion, about the early oral cancers, about locally advanced cancers. We saw about the treatment. We saw how beautifully the panel discussion gave solutions to very challenging cases. And here we are today on the fourth session where we're going to discuss and talk about the rehabilitation and follow-up of the oral cancer patients.
And for the last session, we have rather the most important session, and which is relevant not only in oral oncology in head and neck cancers, which is relevant, so much relevant in present time also in the COVID pandemic, on mental peace. And for this, the speaker for this session requires no introduction. It is the name, the name itself speaks such a lot. Dr. RajGopal, I'll invite Dr. RajGopal sir for this next very important talk.
Dr. Meenu, I hope I am audible.
Yes, sir, you're audible.
Good evening, everybody. Great privilege to be talking to you. I know that we are more than half an hour late. I'll try to be brief and certainly will not go beyond the time allotted to me. The subject carried within brackets in advanced disease. Advanced disease. Would you like to think about what the duty of care of a doctor to a patient is, or a healthcare provider? What's our primary duty? Is it to treat diseases? Is it to diagnose and treat diseases? I must admit that till about 4 or 5 years back, I was never confronted with the question. I never thought about it. Now, in India, the duty of care of the healthcare provider is not defined by law. In some countries like UK, it is. But our Indian Council of Medical Research actually has defined it. The duty of care of the healthcare provider is mitigation of suffering. The duty of the healthcare provider is mitigation of suffering. Are we really doing that? It also says the duty is to cure sometimes, whenever possible, certainly, to relieve often, symptom control, and also to comfort always. That's how the duty of care is defined. And the ICMR adds, there exists no exception to this rule. Now, unfortunately, the way medical system has evolved, particularly in our country, we concentrate almost exclusively on diseases so that we do not treat suffering. What Megha Prati so eloquently describes about pain management reaches less than 2% of the population in our country. Pain is not treated in our country. So we do not treat suffering. Do we sometimes actually add to suffering? Who do you all like to die when your time comes? Would you like to die in an intensive care unit all by yourself? With 100 bleeps blaring around you and your loved ones not even able to touch you? Is that what we would like for ourselves? The National Cancer Grid, which has some 175 cancer centers in the country together, has very clearly given guidelines, one of which is that in advanced disease, treatment should not be in an intensive care unit. Do we follow that? Or do we go on giving artificial life support measures to even with people with whom we know have incurable diseases? Maybe we need to rethink about all this. So Megha Prati in her talk also gave us an excellent image, a representation of how palliative care should be positioned in oncology care. In that image, you might remember that it was shown as starting from the time of diagnosis, gradually expanding. If there is pain at the time of diagnosis, it's treated that. And as time goes on, the relevance of palliative care will keep on increasing. What am I saying? I'm saying that it is not only for advanced disease. If the patient is coming to you with pain, it needs to be treated. Unfortunately, you and I, in our MBBS course, were not taught to do this. In 2014, the World Health Assembly asked all member countries to integrate palliative care into all healthcare. From the beginning to the end, from the time of diagnosis to the end, and end is not with the death of the patient. Because I see that there are 83 people still attending this meeting, and I bet at least 25 of them would have gone through the experience of a loved one dying, and they would know that with the patient, the whole family suffers. So palliative care starts from the beginning, treats suffering along with treatment of the disease, goes through the treatment phase and continues as support for bereavement during the recovery phase. That's how we could position palliative. Now, listen, this is practical. I can tell you that it's already happening. At least in 2 cancer centers in the country, that is Cancer Center at Silchar and Cancer Research Institute at Dehradun. Both have become pain-free hospitals. You know what that means? Every patient is asked every day, do you have pain? If so, how much is it? They are asked to score it in a 0 to 10 scale. And everyone's pain is treated. In these 10 minutes given to me, I am not going to talk about how pain is treated or how any symptom is managed. But what I am saying is this is already being done. As of now, National Cancer Grid is doing a palliative care course, 16 sessions, I think, for head and neck cancer surgeons. 51 oncologists are attending our virtual course on pain management in oncology. And from 2019, medical students have pain management and end-of-life care built into their curriculum. Already. So how did it actually happen? Do I mean to say that every patient will be sent to a palliative care doctor? Not really. Let us try to understand this. I'll just share 3 slides. The first tells us what exactly the problems are. If you note in the top, this is from a Lancet Commission report in 2017. Palliative care is prevention and management of serious health-related suffering, which means the physical, social, financial, spiritual, and emotional problems all need to be taken into account. Of course, I was asked to talk about the mental support, but you cannot do that alone. If this man is sitting like this in pain, unless you treat the pain and unless you answer the question, will my children have to drop out of school? You cannot really attend to the emotional problems. They are all together. You can see that each circle is encroaching onto the other. And if he is worried, where will the money come from for my trip to the hospital tomorrow? How can you address the emotional problems? They are all something to be done together. And the question I was asking is, how can this be done? It cannot be done by Dr. Megha Pradeep in Max Hospital by herself. As it happens in the pain-free hospitals in Dehradun and Assam, every doctor and every nurse knows some basics of palliative care. If somebody is in pain, the ward doctor and the ward nurse treats pain. That's palliative care approach. This is not for those doctors, this is for all of us. Because Megha said something like, someday, not exactly those words, we will be the palliative care specialists and units are for those patients whose pain or other suffering cannot be treated by all doctors. There will be some difficult pain issues where Meghas will have to come in with a nerve blocks or a expert in therapeutics. But most three-fourths of all pains can be relieved fairly simply. So also other symptoms. And I'll stop the screen share. I do see that I have one more minute. During that minute, one thing I have to say, this is also about cancer survivors. Treatment is over, then we expect the patients to be happy, joyful. And if they keep complaining of the neuropathy and they say, I'm always in trouble, and they are not happy all the time, not everybody, because they are always anxious about some things. They are having the post traumatic stress disorder, which they earned in their intensive care unit. And the doctor is sometimes irritated. I gave back your life. You should be happy that you got your life back. But if I am in pain for 24 hours, how can I be happy? A person by Jacqueline Johnson said something. She said, cancer is isolating, and the isolation can hurt more than the pain, more than the cancer. Suddenly, you, the person with cancer, is on outside of the wall. Everybody else is on the other side of the wall, the normal side. Nobody can understand exactly what goes through this person's mind. They need our understanding. Palliative care is also for the survivors. Thank you very much, ladies and gentlemen. Thank you for listening to me patiently.
Thank you, sir. That was indeed a pleasure listening to you, and an eye-opener in so many aspects. And with this, I will call an end to the today's scientific session, a wonderful session. And in spite of the pandemic raging everywhere, and where I don't think there is any person, any family, anybody amongst us who has not been affected. In spite of that, the zeal for academics is there, is always there. And thanks everybody who took time out for this wonderful session, for this academic piece.